Welcome to the Johns Hopkins Medicine online webinar series. Today, Johns Hopkins neurosurgeon, Dr. Gary Gallia, will be speaking about surgery for pituitary tumors. Before we get started, we'd like to provide some user tips so that you are comfortable using this platform. The first 30 minutes of our program will include an informative presentation by our presenter. The last 30 minutes will be dedicated to our live Q&A session. Please note this program is being recorded. To submit a question, please type your question into the Q&A box and click send. Also, your email address will not be shared with any third parties. We will do our best to answer all questions we receive during the Q&A session. Alternatively, you can email us questions and feedback to hopkinsseminars@jhmi.edu. At the end of the webinar, we would greatly appreciate receiving your feedback and ask that you complete our survey. A pop-up window will appear at the end of our program for you to complete the survey. And now I would like to welcome Dr. Gary Gallia to begin our presentation.
Thank you, Amy, and good afternoon. I want to thank all of our participants for joining us today. My name is Gary Gallia, and I'm a neurosurgeon at Johns Hopkins Hospital. One of the major focuses of my practice is taking care of patients with pituitary tumors. And together with Dr. Roberto Salvatore from the Department of Endocrinology, I co-direct the Johns Hopkins Hospital Pituitary Center. Today, I will be speaking about pituitary tumor surgery, and I'm excited to be with you this afternoon. Topics I'd like to cover are several in the short amount of time we have, and they include an introduction and an overview to the pituitary gland and tumors that arise in and around that region of the head, discuss our multidisciplinary evaluation of patients with pituitary tumors, and then go into preoperative, intraoperative, and postoperative management of patients having surgery for pituitary tumors, and highlight this with several cases. Pituitary tumors are very common. This is a pie graph showing the distribution of brain tumors in one of the brain tumor registries over a 5-year period of time. And what this shows is that pituitary tumors are about 17% of all of these tumors in this study. Now they're actually more frequent than that, because these would be patients who were entered into this brain tumor registry, and there are many studies, including several large autopsy studies, that demonstrate that pituitary tumors can occur in 10 to 15% of patients at autopsy, and those are patients who are people who did not have a diagnosis of pituitary disease when they were alive. There is a variance by age. This is a graph from the same brain tumor registry looking at the various different types of brain tumors. These are in adults, and this orange line here represents the tumors of the pituitary gland. And in patients between 20 to 24 years of age, they are the most common brain tumor. And this looks at children and adolescents, and the scale is different here. So they're less common in children, but even in the patients aged 15 to 19, these represent the highest percentage of brain tumors. So very common lesions. In terms of location, where is the pituitary gland? Well, it sits essentially in the center of the head. This is a schematic, which is essentially a section down the middle of the skull, and this is in the center here, the pituitary gland. Right above that is another structure which can be better seen in this higher magnification, where the optic chiasm or the visual nerves sit. And this structure below and just anterior to the pituitary gland is the sphenoid sinus. And we'll talk a lot about that today, as many will have heard about transsphenoidal surgery, which just means going or working through the sphenoid sinus to access this region. And the other thing to highlight is that this sits below the brain. So it's not within the brain itself, but is attached to the brain by this very thin structure called the pituitary stalk or infundibulum. I am going to show several imaging studies today. So I would like to just lay out some very basic anatomy on imaging, so that everyone has the ability to kind of follow along with the imaging. This is the same view that we had looked at before, and this is an MRI scan. Same view, cut down the middle of the head. This is the nose here in the front, the top of the head. This white structure in the middle is the pituitary gland. And the structure that is extending superiorly from that is the pituitary infundibulum, and the optic nerve is seen just above this. This black space just in front of the pituitary gland is the sphenoid sinus. And in this patient, this is very aerated, generating a wide cavity or corridor that one can operate through. This is a comparative slide of a similar orientation, but of a CAT scan. So this, one can see all the dense bone in the skull. And again, this is where the pituitary gland sits, called the sella turcica. And this aerated space here, air is black in a CAT scan. This aerated space here is the sphenoid sinus, which provides the corridor through which surgery is done. Looking at this in a little more detail, this is a cadaveric view just of this region, and one can see the pituitary gland here and the attachment of the gland to the brain, as well as the optic chiasm just above this structure. And just to highlight some of these features on comparative imaging studies, this again is a high resolution MRI scan showing the pituitary gland, the infundibulum, and the optic apparatus. And these will all be important topics as we proceed with our discussion today. And this is a CT scan showing, again, the anatomy of the sella turcica, the region where the pituitary gland sits. If one were to now, instead of cutting the head down the middle, to take a coronal section, this is what one would see if it's done directly through the area where the pituitary gland is. So here's the gland again. The sphenoid sinus is below, and the optic apparatus is above us. Now, on both sides of the pituitary gland are the carotid arteries, which are the main one of the main blood vessels that supplies the brain with blood, and they are on both sides of the pituitary gland here. And interestingly, this artery lives within a vein. So this is the cavernous sinus that we will talk about today. And also within the cavernous sinus, in addition to the carotid artery, one of the nerves that moves the eye laterally sits within the sinus. And then there are several other nerves that move the eye, as well as supply sensation to parts of the face. So these are all relevant for our discussion today. And I'd like to just highlight them pictorially here. This is a cadaveric view that shows the gland again in the center, the infundibulum extending superiorly up to the brain. Here's the optic chiasm and the optic nerves. These large red structures, these are the carotid arteries on both sides of the pituitary gland. And one can see how close they are to the pituitary. And this blue dye, this blue latex in this cadaveric specimen is the cavernous sinus. And so there's venous blood surrounding the carotid arteries, as well as inferior and anterior intercavernous sinuses as well. This cadaveric picture highlights the nerves that are just lateral to the carotid artery. Here's the sixth cranial nerve, and these are the nerves that supply the face with sensation. And just to correlate that with imaging, as we are going to look at a lot of imaging, this is what a coronal view, that's that slice we're talking about, through the pituitary gland. So here is the pituitary gland, the infundibulum, and one can very nicely see the optic nerve here. And all this white space that is seen, that's just brain fluid, that's cerebrospinal fluid. So this nerve is anatomic in location, it's horizontally positioned, and there's fluid all around that structure. And this is the view that one gets when given contrast for an MRI scan, and you can see the same anatomy, the pituitary gland, the infundibulum, and the optic apparatus. So what does the pituitary gland do? Well, it does a lot of things. It's called the master gland in the body for a reason. It does produce many hormones that control other organs in the body. And the anterior gland can produce growth hormone, which is involved in bone, muscle, and organ growth, prolactin, the gonadotropin hormones, ACTH, which leads to cortisol synthesis in the body, thyroid stimulating hormone. The posterior gland produces ADH as well as oxytocin. So really a very active area for a very small region. The pituitary gland is 9 or 10 or 11 millimeters in diameter. So it's a very small structure, but does produce a lot of hormones. And tumors that can arise from this region, depending on what cell they arise from. If it's a cell that produces ACTH, it may cause Cushing's disease, and we'll get into that. as the talk progresses. So there are lots of things that can happen in that region, despite it being very small. And this is a list of some of them. And we're going to talk today mostly about pituitary adenomas. And I generally try to classify these into more broad categories. So there are neoplastic things that can happen in the cella turcica, congenital abnormalities, inflammatory problems, and infectious and vascular issues. In terms of classification scales, there's numerous ways to classify these. Microadenomas are defined as being less than a centimeter, macroadenomas greater than a centimeter, large tumors greater than 3, and giant greater than 4. And a simple way to think about these is whether or not the tumor is confined to the cella turcica where the gland sits, or whether or not there's extension outside of the cella turcica into either the suprasellar cistern or the cavernous sinus or the cella if it grows inferiorly. And these are some examples. This is a very small tumor here on this coronal MRI scan. This is a macroadenoma. One can see it goes up into the suprasellar cistern, hitting the optic nerve, going into the left cavernous sinus on the side. Here's an even larger, a tumor that has more extension, as well as impacting the left temporal lobe of the brain. And this is a giant tumor that extends significantly intracranially up into the third ventricle. Now, in terms of our management of pituitary and cellular lesions, we, like many other pituitary centers of excellence, have a multidisciplinary approach to patients with pituitary tumors. And this includes endocrinology, neuro-ophthalmology, neurosurgery and otolaryngology, imaging, neuroradiology, sometimes radiation oncology and medical oncology. The neuropathology of this is very interesting. We won't get into much of that today, but there's dedicated neuropathologists. And we also have a pituitary conference, as well as tumor boards. So in terms of, and I'd like to just highlight some of the important aspects of each of those groups. In terms of an endocrinological evaluation, this is Dr. Salvatore. I mentioned he and I co-direct the Pituitary Center. He's the medical director of the Pituitary Center. Several questions that come that are important to answer is whether or not this is a functioning tumor or non-functioning tumor. So for example, if the cell that produces prolactin becomes neoplastic and produces excess prolactin in the body, this what generates a prolactinoma. Similarly, if the cell produces ACTH, it can cause Cushing's disease. A growth hormone secreting cell can lead to acromegaly, and so on. So this is very important for us to understand if it's functioning or non-functioning. And the second compartment of that evaluation that is also important is baseline pituitary function. So as these tumors grow from within the pituitary gland, or other tumors arise from near the gland but grow and impact the pituitary gland, the gland may stop working or may be destroyed by that mass. And so that is also important to understand, as those hormones would need to be replaced. From a neuro-ophthalmological evaluation, questions such as, is there a visual deficit related to that tumor? And is that deficit reversible? Meaning if one were to take out that mass by surgery, for example, would one expect the vision to recover? And in this lesion, the mass doesn't even touch the optic nerve. So this person probably wouldn't even need to see an ophthalmologist. But this person that has a tumor that's grown and has impacted the optic apparatus here may or may not have a deficit, would most likely have a small deficit. And this person here that has a larger tumor would most likely have a visual deficit related to that mass. So all important questions when trying to determine the best treatment strategy for an individual person. And the vision loss is very characteristic. It's usually on the sides, and these are just peripheral visual field tests, and anything that is black one can't see in the assessment. And so this patient is not able to see on the sides, and this is the tumor from this patient. Now, in terms of treatment options, there's many of those, and we are going to focus on surgery today, but I highlight this slide just to say that many tumors can be watched conservatively with serial imaging and ophthalmological evaluation. There are many excellent medical therapeutic options for patients. Sometimes, as I mentioned, radiotherapy is important. Sometimes combination therapy is needed to get a control of pituitary tumors. So in terms of key surgical principles, several of these. What's the goal of surgery? Is it to reduce mass effect? Does the patient have a visual deficit from that tumor? Is it a secreting tumor, and is the goal of surgery to remove 100% of that tumor to provide them the opportunity for cure? Is it a question of diagnosis? Perhaps it's an unclear lesion and one doesn't know what it is, and so The goal of surgery is really just to get a biopsy to figure out what that is. Is to make other treatments better. For example, a tumor that perhaps can't be cured with surgery, but can reduce the amount of tumor may make medical therapy or radiation therapy better or more effective or safer with respect to radiation. Is it preventative? Is it a tumor that's getting bigger, but perhaps a person doesn't have symptoms at the time and is a young person, and one would predict that with continued growth that would cause a problem? Well, that is something that surgery often is done for. And then the timing of surgery. Is it an elective process? Is it urgent? Is it someone that has bled into a pituitary tumor, or what we call pituitary apoplexy, where that may need emergent surgery? In terms of the goal here is really maximal safe resection, and we look at high resolution imaging to maximize the approach to the tumor, as well as minimizing and avoiding injury to the nerves and vessels around the pituitary gland. And then preservation and restoration of the pituitary gland. We do try to preserve the gland. And I'll show an example of how we just take the tumor out from the gland. And then, as I mentioned, we'll highlight some of these in terms of some surgical challenges, in terms of cavernous sinus extension, encasement of vessels, and patients obviously with previously treated, for example, previously radiated disease may be more challenging to treat at surgery. There are several surgical options to get to the pituitary gland. This is another schematic, a sagittal view to the middle. This is of a meningioma, but the same sort of location in terms of it being in the suprasellar cistern. There's transcranial approaches where one can go through, take off a portion of the skull to go either underneath the brain or sometimes through a portion of the brain. There's sublabial approaches, which is done through an incision in the upper lip to go through the sphenoid sinus. And then there's direct transnasal operations. This is the most common approach currently, and these can be done either microscopically, endoscopically, or a combination of those. And the majority of these are endoscopically performed today, and I'll highlight this in several case illustrations here. Now, I cannot be a neurosurgeon at Johns Hopkins and not mention Harvey Cushing, who is the father of neurosurgery. He was the first chairman of neurosurgery at Hopkins. In the early 19th century, or in the early 1900s, he and other surgeons did pituitary surgery through the nose. Now, the morbidity and mortality of the operation was very high, and he became so exceptional with transcranial or craniotomies that he sort of abandoned the transnasal operation. And it wasn't until the operating room microscope in the 60s became very popularized that people returned to the transnasal route. And this is a picture looking at, this is a speculum that's in one of the nostrils looking at the pituitary gland through the nose. So this is a microscope that sits external to the patient, and you look down the long corridor to look at the skull base in this region. This is our schematic again. In an endoscopic approach, the endoscope is put directly through the nose, and the camera is right here. So we are exceptionally close to the target. We have wide visualization. There's excellent illumination, and this is the view that we would see. Now, I'm going to highlight some of this because I'm going to show a couple examples that look at this anatomy. So this is the sella turcica. This is in the sphenoid sinus. The pituitary gland sits right behind this bone. This is the carotid artery on the side of the pituitary gland, and this is where the optic nerve is running out into the orbit. So dramatically and profoundly different and improved view endoscopically compared to microsurgically. So we talked about the role of the endocrinologist and neuro-ophthalmologist. Let me head down our list here. And in terms of the neurosurgical consultation, it's to review imaging studies, to discuss the goals of surgery that we mentioned before, to talk about the best approach and the risks of the procedure. And this is our group here, and Dr. Mukherjee and myself focus our practice on endoscopic skull base and pituitary surgery. As I mentioned, most of them are done through the nose today, and this is done collaboratively with our otolaryngologist. This is Dr. Ishii here, who created the endoscopic skull base program with me now almost 14 years ago at Hopkins. It's a two-surgeon four-handed technique, and I'll highlight this in just a moment. And it's important to see the rhinologist and skull base surgeon before surgery to figure out what the surgical risks are, what the anatomy might look like. Does the person have a deviated septum and need perhaps that corrected at surgery? an endoscopy is done in the clinic. We do high resolution imaging, and this is to really define the anatomy. And in this particular person, they have remember, white is bone, and there's a septal spur that comes off on the right-hand side here. So this would obstruct the corridor through the nasal cavity. So this has to be dealt with at surgery. This patient has excess bone. There's not the aerated black sphenoid sinus here. This is all filled with bone. So if one is coming through the nose, all of this bone would need to be removed in order to get to a tumor in this space. And these are some of the things that are discussed at the preoperative appointments. In terms of MR imaging, we've about a decade ago now wrote high resolution submillimetric isotropic imaging studies, and this really provides exceptional detail. This is one of the high resolution studies showing the pituitary gland. Here's the carotid artery by these asterisks. Here's the optic nerve, and you can see all the cranial nerves in the cavernous sinus. And this has been very helpful, particularly in Cushing's disease or small tumors, such as this patient, where we can see this very small tumor off on the left-hand side, whereas the initial outside imaging was negative. In terms of the surgical risks, there are general surgical risks. There's risks to the nose and paranasal sinuses. There's risks to structures around the tumor, and we talked about these, including the pituitary gland, the optic apparatus, and the carotid arteries. There is a risk of a brain fluid leak at surgery. There's tumor-related risks, including both an incomplete resection and recurrence and others, and we go through this in extensive detail in our preoperative consultation. This is an intraoperative view showing Dr. Ishii here and myself working together. The patient's nose is right here. This is the camera that's attached to the endoscope that's going through the nostril, and we're looking at high definition monitors here. This is a higher power magnification showing the patient's nose. Here's the endoscope going up the nose, the camera. And in this particular case, these fluorescent spheres that one sees are attached to a drill, and these spheres are registered to a neuronavigation system that is registered to the patient's preoperative imaging studies, those studies we just talked about. And the accuracy of that registration is about 200 microns. So at surgery, we have a very good anatomical localization. This is what one of those pictures look like. This green dot is where the tip of our instrument is. So in this surgery, here's your carotid artery, and here is something called Meckel's cave, where one of the nerves runs through. We know that we are behind the carotid artery and lateral to it and just medial to this nerve. So it makes surgery very safe for us. Now to go through some examples of a pituitary adenomas. This first case I'd like to show is a person with acromegaly. They had an IGF-1 level of over 1,000. And this is the imaging studies showing the tumor eccentric to the left-hand side with the pituitary gland over on the right and extending superiorly. And there is, consistent with acromegaly, excess bone growth in the skull, including a little shelf of bone above the pituitary gland. And this is just a quick video here showing this surgery. This is now in the sphenoid sinus. The otolaryngologist, Dr. Ishii, has already opened up the sphenoid sinus here. This is taking off the bone over the sphenoid sinus. Underneath that bone, there is a membrane called the dura, and this is just opening up that dura. And here I'm trying to identify the pituitary gland, and this is this little shelf of bone, little shelf of tissue right here, and this is the pituitary tumor, and this is to preserve the normal pituitary gland. And this tumor is very fibrous; it's not soft, and needed to be debulked internally with this cutting instrument. And then we do what is called an extracapsular dissection. So we work around the tumor, and this is taking the tumor off the cavernous sinus, that vein. You can see there's some bleeding from that vein off on that side. And then very slowly and meticulously, we dissect this tumor off of the overlying pituitary gland, which is just above us, and off on the right-hand side. It's underneath this little rim of dura. And then as the tumor is detached, we roll it forward to remove the final attachments. And these are little cotton pledgets that are used both for hemostasis as well as to provide a little counter traction during the dissection. And then this is what the cavity looks like. This is normal pituitary gland. You can see that bony shelf being elevated there by that little suction. And this is how we did the reconstruction here with some synthetic collagen placed underneath the dura. And depending on whether or not there's a CSF leak, there's many different strategies here. This is just another synthetic a collagen matrix being placed between the dura and the bone as a second layer. And this was the mucosa that we had elevated off of the sphenoid sinus. We opened the mucosa to get to the bone, and then we put the mucosa back. And this helps minimize crusting in the sphenoid sinus. The patient's growth hormone level was in the curative range immediately after surgery, and this was the postoperative scan showing preservation of the gland off on the right and on the top with complete resection. This next case is a large tumor now. This extends and it has extracellular extension. So this extends over into the right cavernous sinus, extends into the suprasellar cistern, hitting the left optic nerve. And it also extends below this bone here. This is the clivus, and the tumor has grown down below this bone. So this is, once the tumor is exposed, this is the D means dura, which is the membrane over the pituitary gland. And this is at the end of the resection. This is the normal gland that's left. It's very thin rim of white structure on the top. This is the cut edge of the dura, and this is the large tumor resection, including removal of a portion of the clivus so that we can remove this tumor down to the bottom, to the most inferior extent posteriorly. And this is the postoperative scan showing preservation of the pituitary gland and complete resection. Now, sometimes the imaging is unrevealing or it's negative. And the analogy I like to give is that we spend a lot of time trying to look for things, and if the analogy is a needle in a haystack. If one knew where the needle was, they would find it every time. But if it's not known where that needle is, sometimes one has to destroy the haystack and sometimes may not find the needle. So we do spend a lot of time with high resolution imaging, especially in Cushing's disease, trying to identify where the target is to improve our surgical outcomes. And this is a patient that had Cushing's disease 14 years before we met her through a prior sublabial incision. And this is her high resolution imaging. And the radiology folks thought there was a very small tumor in this space. And what you can see on this scan here is this is all bone in the front. There's not this big aerated sinus in the front. So we know before going to surgery, this is going to be a challenging day because all this bone is going to need to be removed for us to get access to that region. And this is what the original picture looks like once the sphenoid sinus is open. And this is just for comparative sake, what the normal anatomy looks like with the sella turcica, the carotid artery. None of those landmarks are visible. This is after the entire bone is drilled out below the pituitary gland, and we see this little white structure in the back. And with further dissection, we did further skeletonize this, and this turned out to be a pituitary tumor in the bottom of the sella turcica. And this patient's cortisol level precipitously dropped immediately after surgery, and she's been in remission for the past 6 years. I'd like to highlight one additional pituitary adenoma case, and this is another acromegalic to look at the role of cavernous sinus that's often felt to be a very challenging space to operate as, and sometimes it is. This is a person that had prior surgery and had a curative growth hormone after surgery. However, she recurred and was found to have a genetic mutation. She underwent radiation for this recurrence and unfortunately recurred after that. She was tried on medical therapy and had a minimal, really no response in terms of her hormone control. And she subsequently developed a double vision from paralysis of one of her nerves. So this was a challenging situation. She had recently had radiation. She had no control from a biochemical analysis, and she has a neurologic deficit. And this is what her imaging looks like. This tumor is centered in the cavernous sinus. Here's the carotid artery in the back. Here's the carotid artery above, and this is centered in the cavernous sinus with the gland off on the right-hand side. So we took her to surgery. This is now off to the left-hand side. This is the normal sella. This is exposing the entire cavernous sinus as well as the carotid artery as it comes into this region. And this is soft, a tumor, some of it likely necrotic. And because she had a secreting tumor, we removed the capsule, which you can see being dissected off. This is the pituitary gland here, and here's the carotid artery in the back. This capsule is being dissected off, and here's the carotid artery as it comes into the sella and into the cavernous sinus. And she's been biochemically controlled as well for the past 6 years. Unfortunately, she's had a very good outcome. Her imaging showed a complete resection, including a disease in the sinus there. Some options we have for reconstruction. I'm not going to spend a lot of time on that, but sometimes we can just replace the native mucosa. Sometimes we use an autograft taken from another portion of the nose. Sometimes we use alloderm, and sometimes we use a vascularized. If it's a very large case or high flow C. cephalic, we will use a vascularized tissue flap. This is pedicled on the sphenopalatine artery, and this heals very nicely. And I'm not going to go into much more detail on the reconstruction unless folks have questions afterwards. In terms of perioperative care, typically one night in the ICU or the IMC. There's dedicated intraoperative and perioperative nursing that do just neurosurgical care. We do postoperative imaging, usually on post-op day 1, and the hospital stay is about 2 days. Patients are discharged on a short course of antibiotics, and we do blood tests about a week after surgery, serum and cortisol to look for any delayed electrolyte abnormalities. It's not a very particularly painful operation. Most patients do have some nasal congestion and nasal obstruction that is transient. And similarly, this sense of smell and taste may be transiently diminished afterwards. And it's important afterwards to follow up with the otolaryngologist for caring of the nose and the nasal sinuses. And there's care that's set up with the whole team that patients saw before surgery, and the pathology comes back about a week after surgery. I'd like to just talk very briefly about non-adenomatous pathologies. We talked a lot about pituitary adenomas, which are by far the most common thing that happens in that space. As I showed in that earlier slide, there's lots of things that can happen in that space, and perhaps just to highlight a couple of these. This is a patient that had falls and headache and vision loss. On ophthalmological evaluation, she had that bitemporal hemianopsy, that loss on the side. She was endocrinologically normal, and this was a non-secreting lesion, and this is her tumor. The pituitary gland is below this, and this tumor extends superiorly up into the brain, compressing the optic nerve. And this is where we were operating before. And in this case, we had to remove more bone superiorly and anteriorly to be able to access this meningioma, which is what this was. And this is dissecting it off the infundibulum here. This structure is a couple millimeters in diameter for reference, and this is the left optic nerve here, and here's one of the blood vessels in the brain. And we were able to get her whole tumor out, preserving her gland and infundibulum. She did quite nicely. This is another tumor that is arising around the region of the pituitary gland, compressing the optic nerve superiorly. This patient was also hormonally normal and had a visual deficit, and this was suspicious for a craniopharyngioma. And in this view, you can see the optic nerve here and the infundibulum coming from the pituitary gland going up to the brain. And this is the tumor stuck to the infundibulum. These tumors arise from that structure. And this is after we had to cut the anterior aspect of the infundibulum to open up the infundibulum to take the tumor out. And we were able to preserve that structure. She had some very mild transient DI that had quickly resolved. And she's out many years now with normal endocrinological function. Not everything can nor should be done through the nose. This is a patient that had a giant tumor, had multiple surgeries many years ago, 7-8 years before we met her, and she presented with this giant recurrence. So this was taken out with a craniotomy, and this is her post-op film showing a very nice resection here with no obvious residual tumor. Sometimes combination therapy is required, and in this particular person, it's a young woman that had this giant tumor that secreted both growth hormone and prolactin. And so she had an initial surgery via craniotomy to remove the temporal lobe, the lateral component of this. And then this was treated after surgery with radiation. And these are our radiation oncologists. And this is just an example of some of the treatment ports for a treatment, and there's often a discussion on the role of standard radiotherapy versus a proton beam in treating patients if they were to need radiation therapy. So in some closing thoughts here, pituitary tumors are very common lesions. They are benign. They're not cancerous for the most part. There are excellent treatment options that are available. Multidisciplinary evaluation is critical for comprehensive workup and discussion of treatment options. We spend a lot of time looking at high-resolution imaging to understand the anatomy and the extent of the pathology to make surgery as safe as possible. And endonasal endoscopic surgery is currently the most commonly used surgical approach to pituitary tumors. And there is a lot of data on experienced surgical teams, teams that do pituitary surgery more frequently have been demonstrated to have better outcomes and less complications than those that do it less frequently. And I can't highlight enough the role of teamwork in the pituitary center. For those who are familiar with our pituitary center, this is Sandy, who's our pituitary center nurse. Amanda is my coordinator, but every office has their own coordinators that work very closely and seamlessly to try to coordinate care as best as possible. Prior to COVID, this was often done on the same day. Patients would come and see an endocrinologist, would see a neuro-ophthalmologist, and then would see a surgeon all on the same day. So they would leave with sort of a comprehensive evaluation and a defined plan. And this is just a picture from our last pituitary patient education day, which was from 2019. So I would like to thank you for your attention and for taking time out of your schedule to join us this afternoon. And I think that is my last slide here. Amy, actually, that's my last slide. All right, so in terms of some questions here, I'm happy to answer any questions that folks would have. Let me get my screen set up here to look at them. I'm going to read these questions as I go. I was recently diagnosed with a 2mm pituitary adenoma. This was the result of a CT scan that showed a density in the brain cella. It was followed up with an MRI where the 2mm adenoma was diagnosed. Blood and hormone tests were all normal. My symptoms were tinnitus, constant headache, and neck stiffness. The decision was made to evaluate with another MRI in a year. My symptoms have continued. What is the potential of this 2mm mass growing, and how quickly? Well, it's a good question. You know, as I mentioned earlier, and I didn't go through the imaging studies, but in some imaging studies, the incidence of pituitary lesions is higher than that 10 to 15% that I mentioned in the autopsy studies. And thank you, Morag. And so these small lesions that are found incidentally are often called incidentalomas, and the question is sort of what to do about that particular lesion. And I think you did the right things. I think seeing an endocrinologist to do a hormone panel to make sure it's not a secreting tumor is the right strategy. Unlikely it's the cause of the tinnitus or the neck stiffness, and you know, we would just follow that with serial imaging studies, and a year is probably reasonable. Sometimes we do 9 months. Sometimes there are some cysts in that region, and I know that you had mentioned it's a pituitary adenoma. There are some other things that happen in that space, and they're all benign lesions. So if they do grow, they grow very slowly. So depending on one's age, would sort of dictate how long one would need to follow that lesion, sort of what the interval of a follow-up would be. All right. Are there chances of hurting the pituitary gland? How many surgeries do you do each year? What is the percentage of patients that go to surgery? So good questions. We probably do between 150 and 200 pituitary surgeries a year. There's some variability, with that, and some fluctuations, and it's probably in that range somewhere. What percent of patients go to surgery? That's a harder question for me to answer. I would say, probably the minority of people that are found to have pituitary lesions go to surgery. the clear indications for surgery would be someone if they have a large tumor, or if there's, let me say, if there's compression of the optic apparatus where one has a visual deficit related to that. If it's a secreting tumor, so if it's a Cushing's surgery or a Cushing's patient or an acromegaly patient, if it's something that's contained to the sella and we think that there's a high chance of cure with surgery, surgery is often our first choice in that situation. If there's cavernous sinus extension, for example, in a patient with acromegaly, sometimes we try medical therapy first. For patients that have prolactinomas, the first line treatment for that is usually medical therapy. Now, not everybody responds to medical therapy. Some patients have side effects related to medical therapy. Some prolactinomas are cystic, and we know that the cystic ones generally don't respond as well to medical therapy. So, those would sort of be the clear indications, for surgery. But I would say the majority of patients, don't wind up proceeding with surgery initially. Are there chances of hurting the pituitary gland in the process? Well, there is. There's certainly the risk of pituitary dysfunction after surgery, and we do several things to address that. The first is really understanding where the gland is on preoperative imaging studies. So understanding where the gland is before surgery helps you know what you're going to encounter at the time of surgery. And as I mentioned and showed, we try to preserve the gland as much as possible in every surgery. Now, sometimes there is a very thin layer of gland that's anteriorly based, and sometimes that layer of gland needs to be open to be able to get to the pituitary tumor. Sometimes in a Cushing surgery, the pituitary tumor is deep in the gland, and so one needs to remove a small amount of gland to get to that region. So there's certainly the chance of hurting the pituitary gland, but the probability of that is very, very low, a very low single digit, and very, very low. How frequently do you see reduction in symptoms following a surgery? Let me scroll this down. It's at the end of that. It is. For example, memory loss. Well, for patients that have, that's a complicated question. It's a good question. There's a lot of answers that one can give for that. So let me try to classify them in a couple broader categories. So for patients that have visual loss, most often that is reversible. Now, there are some patients you see that said, I've had vision loss for 10 years and I can't see out of my one eye and I never have, and that's not going to recover. But for someone who says, yeah, I noticed over the past couple months or 6 months or a year, I've had trouble seeing, and they have an MRI scan that shows a tumor. It's one of the important features of our neuro-ophthalmologists is that they can look in the back of the eye. They can look at the health of the optic nerve, and they can say, certainly we think this nerve is likely going to recover with surgery. Sometimes they say, I'm really worried about the nerve. I'm not sure that it's going to survive. We should really think about doing surgery as soon as we can. But I would say in general, most patients that have visual loss from a pituitary tumor do improve that symptom. With relationship to headache, which is another symptom that the pituitary patients may have, and not all headaches are related to pituitary tumors, but sometimes patients do have improvement in their headaches afterwards. With respect to secreting syndrome, so a person with Cushing's disease may have high blood pressure, may have diabetes, may have trouble with wound healing, or may have facial symptoms or excessive hair growth, or maybe broken bones, or there's a large constellation of symptoms of Cushing's, and I wasn't able to go through all the details of all the secreting syndromes. But for patients that have curative surgery in Cushing's, and that disease does need definitive treatment, they often have dramatic changes in their body, and those changes happen over a long period of time. So it may be several months that the blood pressure gets better, and people may be on 3 or 4 blood pressure medications, and one of them gets removed, and maybe the diabetes medication gets gradually diminished. Same sort of thing with the weight. The weight doesn't, often patients with Cushing's gain a tremendous amount of weight before their diagnosis is made, and it takes probably an equally amount of time that it took to develop those symptoms to kind of completely reverse all those symptoms. But some of the happiest patients I have in my practice are Cushing's disease patients who've been cured from their disease. Those symptoms dramatically get better. Patients with acromegaly do have some improvement in symptoms, sometimes in their pain. Now, the growth hormone does cause changes in the body that are permanent. So, for example, if your bones get big, that's not going to get smaller after surgery or after medical therapy. So they do get some improvement, but they don't go back to sort of where they were 5 or 10 years before. Now, with respect to memory loss, that's an interesting question there. It really depends on sort of what the etiology of the memory loss was. If the memory loss was from a big tumor that obstructed the ventricular system, where one had hydrocephalus from that tumor, or one had edema in the temporal lobe that caused some memory loss, then in that situation, sometimes treating that a tumor and relieving the compression on the brain would improve memory. For the majority of patients, so if it's a cellular mass, or maybe it's just a supracellular mass that goes up to the optic chiasm, it's certainly possible that memory loss may not be related to that particular lesion. And then, in our group, we typically would refer those patients to a neurocognitive neurologist for, really a comprehensive evaluation, try to help figure that out. Let me see here. What is the average success rate of pituitary surgery? Is there a limit as to how many pituitary surgeries a patient can have, i.e. if the first surgeon was did not provide a cure, or if the tumor recurs? Great question. The success rate of pituitary surgery depends on a lot of things. Depends on sort of what the tumor looks like on initial presentation. Is it a microadenoma? Is it a macroadenoma? Is it one of those giant tumors? The larger, the more complicated the tumor, the more involved of the carotid artery, the more involvement of the cavernous sinus, the less likely that person's going to be cured from surgery. I think there's a lot of variables there in terms of what dictates success of pituitary surgery. There's a lot of evidence out there to say that pituitary centers of excellence, where there are groups that do a lot of pituitary surgery, do have better results. It does depend on a lot of factors there. Is there a limit as to how many surgeries a patient can have if the first surgeon or if the tumor recurs? How many? I don't know that there's an absolute number to that question in terms of how many surgeries a particular person can have. I think it would sort of depend on what the clinical situation is, what the change has been over time, what the goal of surgery is. What is the goal? Is it somebody that has a macroadenoma that maybe had a little left in the cavernous sinus that was challenging to get out, and has that grown just a little bit? Well, sometimes we wouldn't do anything about that. If a person was in their 60s or 70s, we might say, well, let's just watch it for a little bit longer. If it was, a recurrent secreting tumor, Cushing's disease or acromegaly, that was confined to the cella, that we did attempt a curative surgery up front, we go and we look for those. We look for any abnormality on the scan to say, well, is there the possibility that we can operate again and get that person back into remission? I don't know that there's an absolute limit, in answering that question. I guess the other component to that would be sort of, the physiologic state of the person. Is a young, healthy, robust person that, that would be able to tolerate another surgery. But a very good thought there. I've probably, I'm trying to think of patients that have come to us with a couple different surgeries, and then we have operated on them, and a handful of times is probably the correct answer to the question in terms of how many surgeries one can have. Is there postoperative pain, discomfort besides congestion? Let me see here. So, the most common symptoms after surgery are nasal symptoms and sinus symptoms. So it is not, it is not a very painful operation, and really, the surgery that the otolaryngologists do is essentially sinus surgery to get the sphenoid sinus exposed, which is a procedure that is done very frequently in the United States, and patients go home the same day. That is an outpatient procedure. There is some difficulty with breathing. Sometimes, if you get a little piece of dirt in your nose, your nose, can swell up, and, you produce a lot of mucus and some snot. And the same thing happens when instruments are placed in the nose. The nose can produce a lot of stuff. There often is some drainage after surgery. It's usually some blood tinge drainage, which is just expected from that operation. Smell and taste. Smell can be reduced after surgery. I didn't show it on that one slide, but the olfactory nerve, the smell nerves come from just underneath the brain, and when we do the mucosal cuts, it's important to understand where the olfactory filaments are to minimize that. So we make our incisions below the olfactory strip to minimize any surgical issue related to smell. Now, just having blood in the nose and having surgery and having some debris and maybe some dissolvable packing in the back of the nose, certainly, that affects smell, and smell can be reduced afterwards. And smell and taste are linked, and so often taste is diminished afterwards as well. And transient, these things usually recover most of the time completely over several weeks to months. What percentage of patients have adrenal insufficiency after the pituitary tumor has been removed? Great question. So if it's a Cushing's disease patient, I hope folks are getting the sense that the answer to a lot of these questions, it depends. If it's a Cushing's disease patient, one would want adrenal insufficiency after surgery. So, our percentage, Dr. Ishi and I have been doing Cushing's surgery for a long period of time. Our own personal rates of adrenal insufficiency after Cushing's surgery is probably around 90%, which is good, which is what you would want. So in that situation, that is certainly what one would want. In terms of adrenal insufficiency after other different types of surgery, it would be very, very low. For example, if you have, a macroadenoma, where, you have a selective adenoma resection, that it would be very uncommon for that person to develop adrenal insufficiency afterwards. Now, sometimes pituitary tumors cause adrenal insufficiency before surgery, or hypothyroidism or hypogonadism. As these tumors grow and they get bigger, they destroy the pituitary gland. And as they destroy the gland, they can stop that gland from functioning. So sometimes patients have adrenal insufficiency before surgery. So just to extend this question perhaps to what about recovery of pituitary gland function? And we used to think, the dogma was that whatever your pituitary function was when you went into surgery, that's what it was after surgery. And that turns out not to be quite exactly true. There are many patients that have some hormonal recovery after surgery. And similar to the optic nerve question, the longer one has had pituitary glandular dysfunction, the less likely that is. So if one developed adrenal insufficiency 3 or 6 months before surgery and then has sort of surgery, I would say that person would have a higher chance of recovering that axis. I hope that answers that question. What is the occurrence of possible complications of pituitary surgery, a DI, temporary and permanent, CSF leak, and stroke? Great question. I did have a slide there and that highlighted some of these, and just with the constraints of time, I was not able to go into the details of this. So we talked about the most common symptom that patients have after surgery is just nasal congestion, some bloody nasal discharge, changes in smell, those sorts of things. In terms of the other things listed here, in terms of diabetes insipidus, that it is uncommon for one to get diabetes insipidus for a pituitary adenoma. Now, some of those tumors that I showed, for example, the craniopharyngioma that arises from the infundibulum, one would expect diabetes insipidus after that operation. And sometimes if the infundibulum is removed at surgery to cure that tumor, that person would have permanent diabetes insipidus. So again, the answer to this depends on the situation. But for a regular adenoma, it would be very unlikely for that to be permanent. Temporary DIs, probably less than 10% or so. The question here about CSF leak. So great question. The CSF leak risk is similarly low. Now, at surgery, when we're planning surgery, we plan surgery not to not get a CSF leak. We plan surgery to take the tumor out. And sometimes the tumors are separated from the brain by a very thin membrane called the diaphragm. And sometimes when that tumor comes out, there's a small hole in the diaphragm, or sometimes the tumor extends above the diaphragm, or even sometimes we take tumors out inside the brain through the nose, and we make a big CSF leak at surgery. So sometimes at surgery, there's 100% risk of a CSF leak because that's what we plan to do before surgery. As I highlighted in that one slide, there are lots of strategies to sort of minimize the risk of a CSF leak. I think one question that the nursing staff and certainly when you come back to follow up with the team, we ask all the time is whether or not you have water or clear nasal drainage, and that is sort of what we're trying to get at. The risk of that is very, very low. I would say low single digit. I can't remember the last person we had to take back to the operating room or admit with a postoperative CSF leak. Now, endoscopic pituitary surgery began in the 90s. And I mentioned the microsurgical approach was from the 60s up into the 1990s. And then essentially in 2014-ish, endoscopic surgery became more commonly performed than microsurgery. So the early studies looking at endoscopic surgery, as the pioneers in that field were developing techniques, the risk of having a leak at that time was higher, but the current risk of that is quite low. In terms of, just to finish up question 7 here, the risk of a stroke, exceptionally low risk of having a stroke. And a couple of things about that. For anyone that has had a TIA or a prior stroke beforehand, we ask our stroke neurology team to formally evaluate that person to make sure that there's not anything else that can be done or mitigated before surgery. We have had a couple patients after that evaluation who were felt to be extremely high risk for stroke, and we pursued other treatment strategies for that particular for those patients. The most feared complication of pituitary surgery and related to stroke would be an injury to the carotid artery. As I mentioned, those are the two of the 4 main blood vessels that supply the brain with blood. An injury to that blood vessel could lead to a catastrophic stroke, which could be fatal. And that's one of the reasons we do a lot of imaging before surgery in terms of mapping out where that anatomy, where that artery runs, looking at any aberrant anatomy. And also the reason we make a neuronavigation system we do a vascular sequence to do an angiogram before surgery, and we import that into the operating room as well. So we know exactly where that vessel is, and but the risk of that would be exceedingly small. I hope that answers that question. The next question here, which I'm told should be the last question. For secreting adenomas, does surgical success always mean biochemical cure as well? Great question. Great question. So yes and no. I think is probably maybe it depends. Maybe that's my standard answer this afternoon. Is it depends. So optimally, if one has a secreting tumor that is contained within the sella, or maybe there's some cavernous sinus invasion that we think that we can get the entire tumor out, then and that person is cured with surgery, then we would consider that a surgical success. There are some situations, however, where surgery can't cure that person. So it depends on sort of how you're defining success, and I'll share with you kind of my thoughts in terms of how we think about that. So, for example, a person has acromegaly, and there's florid cavernous sinus invasion, there's extension into the brain, there's a bilateral cavernous sinus involvement, not curative with surgery. And the IGF-1 level is above 1,000, so well above the range where one thinks, well, maybe single agent monotherapy, medical therapy is not going to be sufficient to control that person. And so, oftentimes in that situation, we will talk to the person and take them to surgery, not in an attempt to cure them from that tumor, but to reduce the amount of tumor burden that they have to make the other treatments more effective. So in that way, we feel that if we can remove 70, 80, whatever percent of the tumor, and then they can go on to get either medical therapy or radiation therapy to get better control, then we view that as a surgical success, even though that person is not cured from that surgery. So really insightful question. I hope my explanation makes sense there. And do we have other questions? Amy?
I think that's all we have time for today. So we thank everyone for joining, and a recording of the presentation will be emailed out to all registrants tomorrow.
Great. Well, I want to thank everybody again for taking time out of the day to spend the afternoon with us, and I hope everyone has a great afternoon.